Hello Brain Shakers, welcome to the Brain Shakers Academy. Excited for today's session where we're going to be looking at diabetes in pregnancy. Now, what is a diabetes? Diabetes basically is a state that you find yourself in when you have too high blood sugar levels. It means that when we do a blood test, we find that your sugar levels are on the higher side. Now, this is a condition that is very common in people that are then pregnant. But why is it common in pregnancy as well? I guess we are yet to find out. So watch this video until the very end. And if you have not yet subscribed to the channel, what are you waiting for? Please do subscribe to the YouTube channel and remember to share this video to your various groups. Now let's quickly dive into today's session and understand what diabetes is all about. We're going to be looking at diabetes in pregnancy, but before we get to look at the diabetes in pregnancy, it is imperative that we understand what exactly is the source of this sugar that we're talking about, what exactly is the source of this glucose that we're talking about. So the body does make its own glucose from the various systems that it can then utilize within itself to come up with the glucose. But then in most cases, the glucose that is going to be circulating in your system and in your body is going to be gotten from the food that we consume. And in most cases, it is the carbohydrates that we then do take, which are then broken down through a process of metabolism, and then you end up with that glucose. Now, the glucose itself is going to be regulated by the important gland that we call the pancreas. Now, the pancreas is responsible for producing two important hormones. You have the insulin hormone, which then allows the uptake of that glucose after your body has done the metabolism or the breaking down of those carbohydrates. And then you also have the glucagon hormone. Now, the glucagon hormone just works in the opposite sense of the insulin. So meaning that if your sugar levels have gone too low, then your glucagon comes in to strike a balance. So you have some negative feedback mechanism as well here that is going to be functioning to make sure that your sugar levels are within the normal ranges. Now, I have done a video on the negative feedback mechanism. It is readily available on the Brain Shakers Academy's YouTube channel, and you can find that. Please do watch that video as well, so you have an understanding on how these processes are regulated. Now, when we're talking about diabetes, we have already talked about the glucose levels being on the higher side. So if we did find that your glucose levels are on the higher side, then it means that you are already getting into a stage where we are talking about the diabetes mellitus. We normally want this glucose to be around the ranges of about 4 to 7 millimoles per liter. Okay, so it's usually measured in millimoles per liter, but if you are in the United States, you'll probably be using milligrams per deciliter. But otherwise, we tend to want it to be between 4 and 7 millimoles per liter. That is around the normal ranges. Okay, so the diabetes that we're talking about today can be broken down into three main parts. But before we look at the three main parts, let's actually break it down into two main parts. Number one, we can talk about pre-existing diabetes. Okay, so usually it's diabetes mellitus. So if I do DM, then I'm talking about diabetes mellitus. And then number two, we can talk about gestational diabetes mellitus here. So with pre-existing diabetes mellitus, this is where you either end up with what we refer to as type 1 diabetes mellitus, and then you also have type 2 diabetes mellitus. Now, type 1 diabetes mellitus comes in where you have problems of insulin not being produced. It means that the cells that are supposed to be producing you with the insulin to then utilize the glucose and send that glucose for action within the cells is not there. It means that the beta cells, the islets of Langerhans in the pancreas there, they are malfunctional. They are unable to produce you with adequate insulin, and so you will need insulin to be artificially administered through either an insulin pump, or you would definitely be injecting yourself with insulin. And that is why this type of diabetes is usually referred to as an insulin dependent diabetes mellitus, because you need insulin on a daily basis to be artificially administered, because your body is completely unable to produce insulin. In most cases, that is as a result of a T-cell autoimmune disorder that then destroys your beta cells for them to then be unable to produce you with the insulin. Now, when we talk about type 2 diabetes mellitus here, this is where you either have a reduction in the insulin that is then being produced, or you have a reduction in the sensitivity of that insulin. So it means that you have resistance of that insulin that is being produced. So it means that the insulin that is being produced, it could either be inadequate to bring about the glucose itself that has been produced to be utilized, or the sensitivity of the insulin itself is reduced, thereby you're ending up with more resistance, and so the glucose that is there in the body is not then being utilized. So that is for pre-existing diabetes mellitus. Then you have also what we refer to as gestational diabetes mellitus. Now, gestational diabetes mellitus, this is a type of diabetes mellitus that you're going to see when somebody is pregnant. Okay, so this is a woman that then comes in, they will give no history of pre-existing diabetes mellitus. Then when they become pregnant, all of a sudden their sugar levels now become uncontrollable. All of a sudden their sugar levels become high. They are above the normal limits that you would want them to see. So it means that pregnancy now is what has taken them into a state of diabetes. And that's why we call it gestational diabetes mellitus, because it is pregnancy-induced type of diabetes mellitus. And in most cases, these people that have diabetes mellitus or gestational diabetes mellitus, if they are to end with then a form of pre-existing diabetes mellitus, they are likely to end with type 2 type of diabetes mellitus, because we're going to see that in gestational diabetes mellitus, there is also a reduction in the sensitivity of the insulin and then an increase in insulin resistance. So basically, those are the three that we are going to talk about. There are other forms that you can discuss about types of diabetes, but for the sake of this session, we will be looking at gestational diabetes mellitus, which is diabetes in pregnancy. Now, what basically are you going to be looking for as you are looking for diabetes in pregnancy? So if you are trying to do your investigations, you basically do your history. So if you do your history taking, it would reveal that this person has actually either pre-existing diabetes, it will reveal that they have had gestational diabetes in the previous pregnancy. They will also give you a history of familial tendencies of gestational diabetes. So those are people that you then look out for as they are likely to develop diabetes in pregnancy. Then from that, you can also do some blood glucose monitoring. So you can do capillary blood glucose monitoring, but the most important one that you would want to do, especially for people that have diabetes or that have had diabetes, you may want to do what we call a GTT. A GTT is just a glucose tolerance test. You just want to find out how the body of this woman responds and tolerates when it is given to some glucose. So in most cases, you make them fast, I would say maybe overnight, and in the morning then they come in and you do a blood test. So you collect a blood sent to their lab for analysis, and then you give them a sugar. It could be about 75 grams of anhydrous solution. Then you give them, they take that sugar drink, and then 2 hours later without any activity from the time that you give them that sugar content, then they will basically have another blood test, and that other blood test then will tell us the results. So what you want to see is that the first one that you did when they were fasting, it should at least be less than 5.6 millimoles. Okay, and when you do this one as well, which is 2 hours after you give them that, it should at least be less than 7.8 millimoles. Anything outside these then becomes an abnormal reading. It means that the body of this woman is not tolerating the glucose quite well, and so they may then be going into a state of either diabetes or pre-diabetes. Then there are certain other tests that we can do, and this one is what we would be calling the glycosylated or glycated hemoglobin. So this one is used usually for monitoring, especially around 12 to about 13 weeks. So this is the HbA1c. So this is glycated hemoglobin. So we want to find out how much of that hemoglobin that is circulating. So hemoglobin is just an important component that normally carries the oxygen within the red blood cells. It carries the oxygen and transports the oxygen to the various cells. But how much of that element, the hemoglobin element, is vividly attached to glucose molecules? Okay, because once it has attached itself to glucose molecules, then it attaches vividly to the oxygen molecules, thereby releasing only the oxygen molecules in little amounts. So when we do these tests, we also have parameters that we will be looking for, especially when it comes to issues of pregnancy. So you will be targeting at least 6.0%. So 6.0% is about 42 millimoles, okay, per liter. Then 6.5% is going to be about 48 millimoles per liter. And then you have about 10%, which is going to be 86 millimoles per liter. So your target now is to get to below 42. So when you are below 42, it means that this woman is not diabetic. When you get to above 42, so anywhere between 42 and 47, then it means you are pre-diabetic. So when you get above 48, then it means that you're already in a state of diabetes. Now, if you are in a state of first trimester, or you are somebody who is actually non-diabetic, when you do this glycated hemoglobin, you have levels reaching to about 86 millimoles per liter. Then in this case, pregnancy should be avoided. Okay, why? Because the levels are too high, and these will bring about impaired organogenesis that will then lead into congenital abnormalities. So when you are doing your preconception counseling, if you are dealing with somebody with pre-existing diabetes and they are monitored with glycated hemoglobin, if levels are reaching this high, then pregnancy by then should be avoided until such a level where you get to below 6.5. So those are some of the tests that you would run to monitor these pre-existing diabetic mothers, or those that then go in to have gestational diabetes mellitus. Now, what is happening for this diabetes to then come in, especially in gestational diabetes mellitus, where this woman has never been diabetic, and then all of a sudden in pregnancy, then they become diabetic. And this is what we talk about when we talk about the pathophysiology of diabetes in pregnancy. So what is then going to happen? That in the normal sense, the state of pregnancy gives you a diabetogenic state. Why? Because in the first trimester, when you're in the first trimester, what is then going to be happening is that there is going to be increased sensitivity, Okay, this is increased insulin sensitivity. Why is there increased insulin sensitivity? It means that we will need this glucose here to be broken down and utilized and then stored into the reserves. So this glucose will be stored for future use. So it will be stored in the reserve. So within the first trimester, you have high insulin sensitivity, which will get more of that glucose from the carbohydrates that are being taken, so that they are then stored in the reserves. After getting the glucose into reserves, you notice that as you move towards the second trimester, there is going to be an increase in the hormones. Okay, now an increase in the level of hormones. You have human placental lactogen here. You're going to obviously have estrogen also coming into play. You're going to have hormones such as progesterone coming into play. You have hormones such as cortisol coming into play. You have also the growth hormone coming into play. So these hormones are going to be in high amounts. Now, when they are in high amounts, these hormones are actually insulin antagonists. So what they will do is that they will fight the activity of insulin. Insulin in the first trimester had a raised sensitivity. But when the hormones start raising and coming up as you move towards the second trimester, what is then going to be happening is that these ones, they will be stopping the insulin sensitivity and reducing it, meaning that they will be increasing insulin resistance. So these hormones here are the ones that then stop the insulin from utilizing much of that glucose and storing it into reserves. As a result, there will be more of that glucose that will be circulating in the blood, but it is not being gotten used, or it is not being stored into the reserves. So when we do a blood test, then we'll find that your blood sugars have actually gone up, because the hormones here have stopped the insulin from utilizing up that glucose. And then you enter into a state that we are going to call a diabetogenic state. Now, when you get into a diabetogenic state, if that is not regulated well by the body and it is continuous, then it means that your levels now will go beyond the required 4 to 7 millimoles per liter, and then you get into a stage of now diabetes. And if we haven't controlled it quite well, then it means that you may end up on insulin. Now, what is important is that this is a condition which is referred to as a metabolic disorder. Why are we referring it to a metabolic disorder? Because it has to do with the breakdown of carbohydrates, breakdown of elements. Now, if those elements are not broken down well, then it means that they will be in higher amounts. And that is why even the management of diabetes, the first line management that we will be thinking of is, have we regulated the diet? Have we talked about issues to do with exercise to increase metabolism and things like that? And then if that is not well controlled, then we would be talking about the drugs. And if we have gotten to the oral drugs and the oral drugs are not functioning, then we will be looking at issues to do with the insulin administration. Now, that is in brief about diabetes mellitus in pregnancy. But then I look at the actual pathophysiology that brings you the signs and symptoms that you're then going to see, and the other complications and consequences that diabetes is actually going to bring either to the fetus, to pregnancy, or what pregnancy is going to do on the actual condition, which is diabetes. And I do that in yet another video. So make sure that you are subscribed to the YouTube channel so that you don't miss any of this amazing stuff. And if you have not yet turned that notification button whilst you are subscribed, please remember to turn that notification button so you don't miss any of this amazing stuff. Now you have an opportunity to support the channel through stickers. You have the opportunity to support the channel and also become a member of the Brain Shakers Academy. So head on to the YouTube channel, join the membership team so that you can enjoy exclusive benefits that are not readily available to the general public. Now, as always, thank you so much for watching and for supporting the channel, and I will see you when we look at the pathophysiology of diabetes mellitus in pregnancy.